Dr. Lluís Blanch will be presenting monitoring lung mechanics, waveforms, and volumetric capnography.
Good morning. Thank you very much. First of all, I would like to thank Dr. Wichikam for this nice invitation to be here, not only for this talk, but in this scenario. Okay, plenty of history. And my talk will deal a little bit with mechanics and capnography. And well, first, I would like to start my conflict of interest. I mean, this is a patent that I am inventor and also a spin-off of my institution that I have some stocks, as you can see here. And I would like to start with this article. This is a 40-year-old article, and this, I mean, absolutely actual, okay? I mean, in the 75, Peter Suter, Fairley, and Eisenberg, in 15 patients with ARDS ventilated with high tidal volumes, unacceptable today, I mean, they assessed the use of PEEP, 6 to 18. And first of all, he measured FRC with a helium dilution technique. And as you can see here, the predicted initial FRC according, in that case, the response to the PEEP. And the patients with a lower FRC require higher PEEP. And this is the best PEEP. And then use that graph, which is the best PEEP. And he defined the best PEEP, first of all, as the PEEP that reduces physiologic data space. And you will see here how anatomic data space increases, and here is alveolar data space. As a whole, physiologic data space decreased, indicating that the lung, the ventilation and perfusion was in a much improved condition. Secondly, he defined the best PEEP as the one that improved compliance. If compliance is improved, it means that the phenomena of recruitment, I mean, is achieved in those lungs. And in this patient also, the cardiac output here was okay. And also provide us with an excellent investigation 3 years later, which is in CHEST published. It's the relationship between static compliance and PEEP according to the different tidal volumes. And you must remember that on that time they used 13 to 15 tidal volume. So if we go to the highest tidal volume, 15 to 20, is those ones here, 20, when we increase PEEP, compliance goes down dramatically because the lung is fully over-distended. We are creating lots of stress and strain in those lungs. If we use tidal volume, or they use it 5 and measure this, look at what happened in 5. In 5, it's here. I mean, increasing PEEP, compliance increases probably because they were matching the best PEEP with low tidal volume, protecting the lungs, and in that case, improving recruitment. And then there is a bunch of combinations. That was described in patients 40 years ago. So it combined recruitment, it combined protective ventilation, it combined physiologic data space. All of us were there, but probably we don't know how to use all these measurements. So my talk will deal with volumetric capnography to explain what it is and what can be done, and then also some examples and some reasoning according to the 2 recent papers in the New England Journal. So this is the diagram of an ideal lung. It's a lung model representing gas exchange as a function of alveolar ventilation, perfusion, chant, and data space. This is the ideal normal alveoli where ventilation and perfusion is really matched. But in the lung can coexist 2 different settings. This is the pure shunt compartment when there is no ventilation, but there is perfusion. And here is the pure data space compartment. As you will see, there is no perfusion, but there is ventilation. When we combine these, I mean, everything in the airways is anatomic data space, which includes anatomic and instrumental. In the alveoli is alveolar data space, and the combination, I mean the sum of the 2 is the physiologic data space, the one that we measure at the bedside. What we have at the bedside is the waveforms. I will talk about waveforms, I mean, in my second lecture as well, but the most important ones is airflow. The other one is pressure. I'll let pressure for the afternoon lecture. But flow is very important, and also capnography. And as you will see here, this is the capnogram that we see at the airway. When we see, this is, instrumental data space, the transition in that case from, air, the alveoli, to the airway, and this is, pure alveolar air that, it's end-tidal CO2 in the alveoli, and according whether there is more ventilation or more, in that case, or less perfusion, we can see, these variations on the alveolar, in that case, and not end-tidal, but alveolar CO2, as you will see here. But at the airway, what we see is this capnogram, which is the PCO2 as a function of time. If we took examples, examples of what is, in that case, pure, in that case, alteration in the data space, is the pulmonary emboli. This is a normal capnogram, entitled approximates arterial PaCO2. This is time, and if there is an obstruction in this model of emboli, you will see that there is no end-tidal. So, the figure is the same, but the end-tidal is decreased due to this emboli. Here, for example, we can observe what's going on in a capnogram when there are profound anatomic geometric alterations due to perhaps flow limitation and COPD. Again, this is the perfect capnogram where the transition of the phases is okay, but here, it's the high content of PaCO2 because there is this huge flow limitation. So at the end of expiration, still there is CO2 coming out. CO2 that approximates venous mix CO2. That's why if we increase expiration, end-tidal CO2 rises in this type of patients. And more important, the transition from phase 2 to phase 3 disappears because there is anatomic alteration. So this configures the typical, capnogram of obstructed patients, asthmatic patients. We can complicate this a little bit further because now ventilators, many manufacturers can provide us with the CO2 as a function of exhale volume, where the area under the curve, in that case, is the effective alveolar ventilation. So phases are more or less the same, and also end-tidal in this situation, could be very close to PaCO2 in normal patients or very wide in patients with lots of data space and or sometimes in patients with COPD with short expiratory times. We can also divide this diagram of CO2 as a function of expired volume to partition in effective alveolar ventilation, alveolar data space, and anatomical data space, and here is the equation. This is the Enkhoff modification of the Bohr equation for the measurement of the physiologic data space, which is the PaCO2, the mixed venous CO2, the mixed expired CO2 divided by the PaCO2. And here, physiologic data space is subdivided, as I said before, in anatomic data space and alveolar data space. So this is what we have at the bedside, but we need more. First of all, to understand that when we measure the Enkhoff modification of the Bohr equation, we are measuring something which it's a little bit of Shan and data space. So it's a combination of both because it includes some pure Shan areas, as you will see here, and pure data space areas. And for example, in a patient with acute lung injury or RADS, this is a combination of the two. So when we are measuring physiologic data space, we are including, the Shan effects on data space and also data space. And now, why data space is important at the bedside? Because it's one of the first predictors of outcome in patients with RADS. And this is very important. If we measure physiologic data space in a patient with RADS at the first day, and data space is very high, the probability to die is high. Why that? Because in that case, the data space fraction reflects injury of pulmonary capillaries by thrombotic or inflammatory factors. It also can, represent obstruction of pulmonary blood flow in pulmonary circulation and also represents lung areas with high VQ. So there is an impairment in CO2 excretion. Here is the results of Nacton paper in almost 200 patients showing that in these quartiles distribution mortality is very high when data space, physiologic data space is very high. Do this happen in patients with severe RADS? No, it happens also in patients with intermediate. I mean, if we replicate this with the Berlin definition, probably we will find these results as well, saying that in the early phase or in the intermediate phase, as you will see, I mean, it has prognostic value, the measurement in that case of RADS. So, I mean, if there is mild disease, mortality is less, but as soon it progresses, I mean, mortality increases. And the evolution is also important. This is one of our investigation on, I mean, physiologic data space, and we derive, this is a computational index, which is alveolar ejection volume, which comes from the plot of CO2 elimination as a function of expired volume, and then fitting, in that case, this elimination. So we create that index, and when we analyze this in a series of patients with RADS, at the beginning, I mean, at the beginning, both were high physiologic and alveolar ejection ratio as a function of tidal volume, but at 48 hours, the evolution of this index and physiologic data space, I mean, shows the patient in whom the probability of dying were higher. And here you will have the sensitivity, specificity, and the ROC curve. So, I mean, this index and the physiologic data space index behave the same. So if this, I mean, is not improving over the course of RADS, the chance of the patient to do not survive, in that case, is increasing. Having said that, I mean, I will show you an example of how volumetric capnography tells us pure recruitment. This is an experimental animal with E. coli pneumonia. What is here is flow. This is reverse. This is inspiration, and this is expiration. This is airway pressure, this is lung recruitment, and this is the lung volume measured because the animal was inside the body box. So here is 0 PEEP, and you will see at 0 PEEP that the lower end tidal CO2. When we applied PEEP to 20, look at what happened in the CO2. There is no expired CO2, there is almost no, I mean, no expired flow, and there is an increase in the lung volume up to a point where this equilibrates. This is the phenomena of tidal recruitment. Okay, this is nicely described by Katz several years ago, but here equilibrates, and then end tidal CO2 came up, tidal volume was the same here. The difference between pressure at end expiration and peak pressure decreases because this represents, in that case, recruitment. And if here we calculate the delta P that I'm going to comment, so a measurement that we use for many, many years at the bedside, which is the difference between the plateau and the PEEP, and see, I mean, how it behaves in patients, you will discover that the delta P here, I mean, decreases because this is recruitment. So at the bedside, those tools, waveforms and capnography, are useful to follow what are we doing, the setting up that we are doing in the ventilator. So now, this is a paper, again in animals, showing more nicely what's done and also using some measurements of the CT scan. You will see here in these lavage peaks, so inducing RADS by depleting surfactant in the lungs, and again here using low tidal volume, you will see the behavior in that case of data space when the PEEP was decreased. As you will see here, decreasing PEEP, data space increased, and CHAN also here increased. When the partitioning of data space was done here, starts at PEEP of 24, decreasing PEEP, alveolar data space increases, so meaning that there is, in that case, lots of collapse, and anatomic data space, in that case, as you will see here, also decreases here. This increases and this decreases because decreasing PEEP, I mean the diameter of the airways also decreases. As a result, at the bedside, depending on this combination, it's hard to see changes in physiologic data space. That's why in some papers showing no response with PEEP, other papers show that there is in some patients response, and other papers show that maybe with PEEP, physiologic data space, is not improving. So in the bedside, we can see this, but if we measure, we must know this physiology to interpret that. And now I'll show you another example on experimental animals, taking into account all the variables that we see at the bedside, the most important ones, which is EKG, arterial pressure, pulse, the saturation, pulse oximetry, CO2, flow, airway pressure, and tidal volume in this experimental animal going from 0 PEEP. It's not really a recruitment maneuver, but we increase PEEP here, as you will see, and then in this animal, which is not well resuscitated, because that was the point to show here, what we show is that an immediate decrease in mean systemic pressure. We lost the signal of the pulse oximetry. As you will see, end-tidal CO2 went down by the two phenomena, hemodynamic and probably overdistension, and, you can see also here the variable. So all what we have, the monitoring tools at the bedside when we play, in that case, trying to recruit the patient, open the lung with PEEP and so, tell us very, very important information. Another example, this is published in Minerva, these two examples in a study that we did together with Jordi Mancebo, trying to see the response of patients with RADS to recruitment maneuvers, the amateur recruitment maneuvers. So in pressure control, rising PEEP, as high as 40 to 60, okay? 60, the difference between PEEP and pressure control, 20, 60 and 40 of PEEP. And here is a patient that responds. This is very nice. Tidal volume is the same, minute ventilation is the same. So we increase PEEP here, as you will see. And again, PaO2 rises from 70 to almost 400 at a stage for 2 hours. And look at the PaCO2. From this point, went down. That means that physiologic data space, in that case, decreased. So the patient improved because there is recruitment in that condition, okay? But this is a drama. And at the bedside, sometimes we don't know. Maybe you will tell me today, this patient is not for recruiting, it's for ECMO. Agree. This patient is not for what you did, maybe it's for proning. I agree. But at the bedside, when you recruit, sometimes you recruit. And then, if you are there, this is earlier RADS, PO2 is low, and you do recruitment maneuver, 35, 18, 40, 25, 60, 40, and then we stop the recruitment maneuvers because the recruitment is poor, as you will see here. But what's going on at the end? Look at the PaCO2. It's here. This patient, physiologic data space, deteriorates a lot. The lung condition deteriorates a lot. So, with these measurements, if we have physiologic data space at the bedside, is okay, but if not, PaCO2 is going to track changes in physiologic data space, provided, minute ventilation and tidal volume, in that case, is the same. And if we only play, in that case, with PEEP. So take everything into account when you do certain maneuvers or setting up the ventilator at the bedside. So now I would like to extrapolate a little bit these two papers, okay? Because I need to speak on mechanics and waveforms and capnography, and I took these two papers. The first one is the transpulmonary pressure paper. So Talmor published this very nice investigation in the New England. Now many people, is back to study transpulmonary pressure in patients with RADS. Then they speculate that patients with high estimated pleural pressure under inflation may cause hypoxemia. In such patients, rising PEEP to maintain a transpulmonary pressure may improve aeration and oxygenation without causing overdistension, and the opposite. In patients with low pleural pressure, PEEP perhaps should be maintained at low. So what they did is selected two groups, esophageal pressure guided group and control group. These are FiO2, in that case, PEEP tables, in that case, and FiO2, and a combination according to the pressure at end expiration in the esophageal tracings. So the reasoning for that was they set PEEP such a level the transpulmonary pressure during an expiratory occlusion, I said here, esophageal, transpulmonary pressure stays between 0 and 10 centimeters of water. So keeping transpulmonary pressure, in that case, during expiration, positive, meaning that or assuming that the most alveoli, should be open. When they look at, here the results are better oxygenation and compliance in the esophageal guided group, and the paper was not powered for mortality, not designed to study mortality, but the differences in mortality were really, really, really high. In between the two groups, 17 in the esophageal group, 39 in the RADS stable group. And here is the key point. The transpulmonary pressure at the end expiratory transpulmonary pressure in the esophageal guided group, in that case, was positive. So that was the reasoning. This is a patient with PEEP, low tidal volume, as you will see at the bedside. Using the esophageal pressure, they have the transpulmonary pressure, which here, as you will see, at end expiration is negative. And what they did is, by increasing PEEP, rising the transpulmonary pressure positive, so compliance improved. There is no real data on physiologic data space, but if we also have this data, compliance, together with the PaCO2, without touching minute ventilation, without touching tidal volume, in that condition we have an important tool, that is assessing also, physiologic data space. And now just my two slides, last slides, is the paper of Amato. The paper of Amato, in fact, tested what he did in 98. If you read the 98 paper in the New England, one of the variables that predicted mortality was the delta P in that paper, which is the difference between the plateau and the PEEP, according of what we do, setting the ventilator. So they took data on, I think, five studies, and they did what's called a sophisticated statistical analysis, mediation analysis to assess, and the driving pressure, which is the delta P, which is tidal volume divided by compliance, or this formula, which can be routinely calculated for patients who are not making inspiratory efforts as the plateau pressure minus PEEP. This is tricky because, we should not only take a look if the patient is making inspiratory efforts at the beginning of the inspiration. We need to see if there is no reverse triggering. So inspiratory efforts in the middle, because then the plateau decreases. So when you take that measurement, be really sure that the patient is not doing any kind of inspiratory efforts throughout the inspiratory cycle. So they assess more than 3,000 patients enrolled in, in 9 previously randomized reported trials. And this is perhaps one of the nicest figures that I see in the last years, okay? Which is, in all this bunch of patients divided in these cohorts, and this is a plot of airway pressure, resample matching PEEP, okay? And this is the delta pressure. If PEEP is matched here, and delta pressure increases, this is tidal volume, perhaps a little bit more stress and strain. When they look at, in that case, the relative risk of death, it's increasing when there is an increase in delta pressure. So what we have at the bedside, we have tools. Delta pressure is one, but also we have PaCO2, physiologic data space, So maybe we need to combine a lot of all of them. The other one is they rise at PEEP, keeping delta pressure constant, as you will see here in these different, groups of patients. And then mortality is practically the same. But this is the important one. So what we do at the bedside is we don't want to go to higher than 30. If the patient, there is no impairment in chest wall compliance, and so there is no huge intra-abdominal pressure. And in that condition, they increase PEEP, keeping the same plateau pressure. That means that if we do that, keeping the same plateau pressure, what we are doing sometimes is decreasing the tidal volume up to a point. And in that condition, the risk of death is going down. If here the delta pressure means that compliance is improving also in that group, and probably physiologic data space is improving. But if this is what is demonstrated. And physiologic data space is some nice physiologic measurement that we have at the bedside. So we need to use both. So in conclusion, understanding the physiology of ventilation and measuring simple mechanics and the data space fraction at bedside in patient receiving mechanical ventilation may provide important physiological, clinical, and prognosis information. So Even if now we have lots of rules how to manage patients in mechanical ventilation, never forget the physiologic meaning of these measurements. Studies are warranted to assess whether continuous computing of different mechanics and capnographic measurements is useful for risk identification and stratification. Still, we are not there. Tracking the effects of therapeutic interventions and also setting mechanical ventilation. So we have more work to do. Thank you very much.